Second degree heart block. It is divided into two, Mobitz1 and Mobitz2. Mobitz1 is also known as Wenckebach phenomena. It is characterized by progressive prolongation of the PR interval until a dropped beat occur. So if we check the electrical conduction of the heart, so the pulse it's generated from the sinoatrial node, then it goes to the AV node here, then it's being transferred to the bundle of fish, then to the left branch, right branch, and to the Purkinje fiber, and then cause the contraction of the ventricles. So the SA node, it starts from the SA nodes and it goes to the AV node, then to the bundle of fish, then to the left and right branch, and then to the Purkinje fibers, and then the contraction occur. So the problem is not in the SA node, not in the conduction here. The problem is within the AV node. So there is a problem here. There is a lesions here in the AV node. Normally the AV nodes have a pause or delay of 0.1 second, but in this case there is even more delay through the electrical activity to pass through the AV node. So the problem is within the node, within the AV node. That's why it is also intranodal. It is also known as intranodal. So if we check on the ECG, we measure the PR interval, because the P wave, the PR interval, it's the starting of the P wave and the starting of the Q wave. So this is the PR interval. Physiologically, there is a delay to allow the filling of the ventricle. Physiologically, there is a 0.1 second of delay, but in this phenomenon, in this Mobitz1, there is a abnormal amount of delay. There is more than the physiological time of delay in this Mobitz1. And how we are going to see it? If we check the PR interval, we are going to check the PR interval. So in this, the PR interval is around this much. So if we check the another next one, the PR interval as compared to the previous one, it is increased. If we go to the next one, the PR interval is even more increased as compared to the previous ones. And now if we see the next one, we see the P wave, but we did not see the QRS complex. So here is the missed beat. So here is the missed beat that is not being transferred from the AV node, that is not being conducted from the AV node. If we see the next one, here is the P wave. From here till here, the PR interval is not equal to the previous one. So the PR interval is longest immediately before the dropped beat. So if this is the dropped beat, we see the PR interval is longest as compared to the previous one or the next one, and the PR interval is the shortest immediately after the dropped beat. So this is the dropped beat, and we see the PR interval is comparatively way smaller than the previous one. So it is the defining or characteristic feature of the Mobitz1. The missed beat, before the missed beat, this is going to be the longest PR interval, and after the missed beat, it's going to be the shortest PR interval. So this is how we know that it is the Mobitz1. So the causes of Wenckebach phenomena and Mobitz1 is due to it can be due to the drugs, that is beta blockers, calcium channel blockers, digoxin, amiodarone, and due to the increased vagal tone or the inferior MI, inferior valve MI, myocarditis, and following cardiac surgery can also cause mitral valve repair, tetralogy of Fallot repair. So what are the signs that are typically for Mobitz1? Mobitz1 is usually benign rhythm, causing minimal hemodynamic disturbance with low risk of the progression to the third degree heart block. So the patient is asymptomatic, does not require treatment usually. The patient who are symptomatic can usually respond to the atropine, and permanent pacing is rarely required for the patients. So this is the Mobitz1. So Mobitz2 is usually due to the failure of conduction at the level of his Purkinje system, that is below the AV node. And Mobitz2 is likely to be due to the structural damage to the conducting system, example infarction, fibrosis, necrosis. And Mobitz2 is an all or nothing phenomena whereby his Purkinje cells suddenly and unexpectedly fail to conduct a supraventricular impulse. So if we see, the impulse is being generated over SA node and it's being transferred to the AV node, then to the bundle of fist and left and right bundle branch, and then to the Purkinje fibers and the ventricle contracts. So the problem is within the bundle of his. So there is a lessons present in the bundle of his that cause this Mobitz2. So this is the SA node, this is the AV node, and here is the representation of bundle of his. So if we see, the PR interval is from this area, from SA node till the ending of the AV node conduction. From A, B and C is denoted by PR interval. So if we see, the problem is in the D, that is the bundle of his. So the PR interval is not going to be affected in this case. So if we see the ECG, just a second. So this is the ECG. If we see the ECG, if we measure the PR interval like this, from here to here, this and this, it's same. If we check this and this, it's same. See, it's same. But we see after the P there is a QRS complex here, there's a QRS complex over here, and there is also QRS complex here. But after this P, there is a missed beat. There is no QRS complex. So over here, there is a missed beat that if when we see over here, there is a missed beat, and that is because there is a conducting problem, that all or nothing phenomena whereby the Purkinje cell suddenly or unexpectedly fail to conduct the impulse. So over here we see there is a missed beat. And how we are going to distinguish from Mobitz1 and Mobitz2? We see there is no interference in the PR interval. The PR interval is same in on all the QRS. Just the missed beat is there. So this is how we are going to differentiate between the Mobitz1 and Mobitz2. The causes of Mobitz2: anterior MI due to septal infarction with necrosis of the bundle branches, idiopathic fibrosis of the conducting system, cardiac surgery, especially surgery occurring close to the septum, example mitral valve repair, inflammatory conditions such as rheumatic fever, myocarditis, Lyme disease, autoimmune, SLE, systemic sclerosis, infiltration myocardial disease, this amyloidosis, sarcoidosis, hyperkalemia, drugs, beta blocker, calcium channel blocker, digoxin, amiodarone. And the clinical significance, like Mobitz2 is much more likely than Mobitz1 to be associated with hemodynamics compromises, severe bradycardia, and progression to third degree heart block. Onset of hemodynamic instability may be sudden and unexpected, causing syncope, strokes, attacks, or sudden cardiac death. The risk of asystole is around 35% per year. Mobitz2 mandate immediate admission for cardiac monitoring, backup temporary pacing, and ultimately inserting of a permanent pacemaker. So if we summarize the Mobitz1 and Mobitz2, how we are going to differentiate, again once again, we see the PR interval. If we see the PR interval over here, it's increasing, it's progressively increasing in Mobitz1. And when we see the missed beat, we see before the missed beat, we can see over here there is the longest. Before the beat, we see the PR interval is the longest, and after the missed beat, the PR interval is the shortest. So this is the differentiating feature between Mobitz and Mobitz2. And in the Mobitz2, the PR interval is not being changed because it's not being affected. only we can see the missed beat over here. So that's all. Thank you for watching.